So welcome back, everybody, to Simple MD, the podcast. I'm your host, Dr. Ari Sofer, and I have a great show today. This is going to be a terrific episode about really being overweight and obesity and ultimately solutions, like how to get that weight loss. So we're going to get right to it today. Sit back, relax, and remember to, subscribe below and send us in your questions. But we hope to give a complete episode today because I think we have pretty much one of the largest gatherings of the most experienced experts in the world on weight loss. So I'm going to introduce them right now.
Let's keep it simple, start today.
We have the first special guest is a gentleman that I got to know really on a personal level locally. His name is Dr. Alan Mandel. And Alan is not only a tremendous human being with a great heart and a very skilled doctor of chiropractic, but he also is probably the leading internet doctor. He's got a podcast, not a podcast, really more of a YouTube called Motivational Doc. Many of you have seen it, maybe on your other social platforms like TikTok and whatever. And he has a following from all over the world. I know because I've been on his segments, and I got questions and followers from every reach, from Afghanistan to India to wherever, and people love to hear how he really brings information to the internet, to viewers. We have two other guests that are in the green room that will come in a bit later that will give us not only the nutritional and exercise perspective, but they're also going to give us information about what to do when you really need surgery. So we have a Beverly Hills bariatric surgeon extraordinaire, a gentleman named Dr. Donald Waldrop, who flew in to be with us today. And then we have, after you've lost the weight and now you need the body contouring that happens with long-term weight loss, we have a Hopkins-trained Miami plastic surgeon, a very well-known and strong personal friend of mine, Dr. Andrew Montague, who will also be here today. So we have a lot of information to unpack. And as always, my partner in crime, Adam Custon, is going to be here to help keep it simple for everybody so that we can take all of this complicated stuff and make it, well, a little more simple. So why don't we sort of get going here, Adam? Maybe
Great to see you again. Beard's looking better and better every week. Love it.
Thank you.
Looking handsome there.
Yes, I've never, well, I don't know about that, but I got to tell you, like, there's just something about doing this that is very calming,
Not only for you, but people are looking at you too.
Yeah,
You're definitely thinking about something.
Yeah, I'm very contemplating now.
I'm the only one here who doesn't have one.
That's
We're going to work on that. By the end of the show, you're gonna look like Nick Offerman. Okay, so we're here today to talk about obesity, and why don't we just begin right at the top and do your best to keep it semi-clinical. Walk us through what obesity is, and then we can begin to sort of unravel the root causes and some potential solutions for it.
Well, sure. So let me give you some quick stats. So, as a cardiovascular doctor in particular, it's been an issue for us for a long time. We know that leads to problems. So 42% now, and that's a much bigger jump than when I first started training really in the 90s, 42% of all adults are considered obese and have obesity-related conditions, which include heart disease and stroke, and obviously type 2 diabetes, even certain types of cancer. But the worrying part about all this is 20% are under 20. And that's not a good rule, man. That 20 under 20, that is a
20% of people under the age of 20 are considered obese.
Yes.
Wow.
So what causes this? There's obviously two parts. There's nurture and nature. There's the genetics and environment. Now, the genetics has become much more interesting as we've identified dozens of genes that are related to obesity. So a lot of this is not your fault. It's not one's fault. No, not your fault, clearly, but is not anybody's fault. It is a genetic predisposition. But nature has a role. Nurture, meaning environment, also has a role. So a lot of it has to do, and we can see in the industrialized countries that have dense, calorically dense, high calorie packed in foods, the supersized, type theories, that plays a role as well. And then there's this third theory where you can take a genetic situation and turn it on by the nurture, by the environment. So those are the three reasons that really, why does weight gain happen?
And we may be putting the cart way before the horse, but do you think that gives some people a free pass to throw their hands up and say, I'm not in control of this, something else is in control of this? Or, I mean, to hear that between 40 and 70% of the obesity is related to genetics and not related to behavior or anything that you could do to influence it, I'm just wondering what the balancing act is for patients.
Well, there's this thing called epigenetics. I'm not going to get into it, but the bottom line is that you can have a gene, but you can turn on that gene, right? So you can turn it on by things that you can then eliminate. So, Dr. Mendel is going to talk to us in a minute about how to do a lot of that. But just because you have the gene doesn't mean you necessarily become obese. But if you have the gene and then you put yourself into an environment of, high dense caloric foods and not enough exercise because we've industrialized ourselves, we don't have to exercise as much, then you have it. So you can never throw your hands up, but you certainly don't have to also feel so horrible like, you did everything. Part of this is actually, probably millions of years of evolution.
So I have one more question related to that, just to make it simple. So from the genetic perspective, two people with differing genetic makeups, both of them consume in the good old days, and maybe it's different now, 2,000 calories a day, and they have the same exercise patterns, as much as you can control for other things. One of them puts on weight and one of them doesn't. Is that really what you're saying?
Yes, that's what I'm saying. And there's a lot of twin studies out there. There's just a ton of research showing that the environmental factors play a role, but they have to play a role in the right person with the right genetics. Oh. So, as we learn, what are these genes that react to certain types of foods or certain types of exercise, we'll have all the answers. Right now we have a sort of a guide towards the answers, things that work for all people. But very shortly, we're going to have very specific, we're going to take your DNA. How are you going to lose weight? You're going to take your DNA, and this is what you can or cannot do, eat and cannot eat, and this is what you can or cannot expect. Very close to that. Not 100% there yet, but very close to that. And in the meantime, we have guys like Dr. Mendel that can help with the different foods and exercises that can, you can try and see if it works for you.
Got it.
Then we've got a whole host of medications we can use that work for populations, not individually gene
and
specific.
We're gonna talk about those as we get into it. So my last question. So we set the table before we started to talk to Dr. Mendel about how to address some of these things. Is nearly half of the adult population is obese. He said 42%. I'm a marketing guy. I'm rounding up to half. It's easy to talk about. What's the definition? How do you know you're obese? Other than feeling full at the end of a meal probably isn't it. So how do you know you're obese?
So honestly, this is the most difficult thing. We can only do this in sort of large scale studies and put everybody in a particular box, which we know is not the right way to do it. But the numbers are pretty specific. So it's if your BMI, which is a way of sort of taking your height and weight and deciding really arbitrarily that it doesn't matter if you're necessarily big boned, small boned, where you're from, whatever. We're not adding in cultural differences. We're simply saying that BMI is
is what? It's body mass index.
Body mass index. Yes, very good. Very good at it. Like how you ask a question and then beat me to the answer.
Yeah,
it's
well, I do it at home too.
So anyway, so you got about a 25 and above is considered to be overweight. And then once you break the 29.9 barrier, you hit 30, you're considered obese. And that goes with a whole host of stuff.
And it seems like a really weird scale.
Yeah.
So what's max BMI is 100? Is 50? Like what's the max BMI?
I haven't seen 100, but I've certainly seen 40 plus.
Okay.
And those are
all right. So it's really I'm making this up again on a scale from 0 to 50. If you're like past that midway point, you're considered.
Yes.
You're on your way to obesity or you're obese. because BMI is sort of an arbitrary number.
Right.
It's not a metric scale. It's some other
Very
imperial
mathematical way,
scale.
from 0
Got
to
it.
50, yeah. So 25 and above,
Okay.
overweight, 30 and above, obese, and then there's levels of obesity beyond that. And then there's, of course, we take people into different sort of shapes because we're trying to figure out, well, what's the difference between a sort of a pear shape or an apple shape or an hourglass or the inverted triangle. You've probably heard of all those different types of shapes. So scientifically, we've done that without a lot of great success because, we do know one thing. We know that men that carry it sort of in the belly,
Right.
the typical, I guess pear shape, are at most risk.
Okay.
Women as well, that abdominal obesity is the most toxic, and controlling that is both difficult, but it's also the most where you get the most improvement from a total metabolic perspective.
Is there a scientific description between the pear shape and the apple shape? Because one man's pear may be another man's apple. I'm not really sure if that.
I think I really dispel those.
Okay.
I like to go with just the abdominal
Got
obesity.
it. That's the
only
riskiest,
thing
the most of most concern.
I agree.
Great. So maybe we ought to talk a little bit about the effects, and then how to mitigate some of those effects. Maybe really helpful to give people a clear
Well, the effects
perspective.
really affects. Then I really want to jump into all the great stuff that Dr. Mandel has to say. But we know the bad stuff, right? The bad stuff is you have a much higher risk, if not it causes diabetes. Diabetes then in turn, type 2 diabetes, meaning it's not an immunologic reaction. You basically just exhausted your pancreas a little bit. When that happens, you get high risks of stroke, high risks of high blood pressure, high risks then that lead into myocardial infarction or heart attacks,
Right.
Even cancers. And then, of course, the big, the extra weight causes, things like arthritis and sleep apnea, which we know then, again, back to stroke and heart attack and so forth, gallbladder disease, all these things
All these
happen.
stacked up.
Yep.
My mic. Stacked up consequences
Yep.
of early on.
Yes.
And to me, the soundbite of the day so far is exhausting your pancreas. I mean, if you just kind of internalize that for a second, like you've worn out one of your organs.
Right.
And then because of that, all these dominoes begin to fall in your body.
Like an alcoholic can wear out their liver,
Yep.
a overeater
Can
and
wear out their
less
pancreas.
exerciser can basically blow out their pancreas.
And there's probably one thing which, again, from a non-clinical standpoint, but certainly a macro standpoint, is your quality of life stinks.
Yeah.
Right? I mean, as you get past a certain point, all the things that your mind wants you to do that your body can't follow through on probably creates some degree of sadness, depression, and all these other things where you can't fulfill your best self because you just can't get up and do
that's
it.
a cycle, right? So
Yeah.
it makes you want to then eat more and
Right.
stay on the couch longer. So the good thing is we're here about solutions, and it's all 100% solvable. It's all 100% reversible.
Great.
So we really need to, sort of get to that. Now let's talk about the diet part of that before we get to the exercise. The diet part of that. So there's one diet that sine qua non is most accepted by every society out there: American College of Cardiology, American Medical Association, everyone, and that's the Mediterranean diet. The Mediterranean diet is more of a lifestyle, but it's basically a pyramid where sort of fruits and vegetables are at the bottom, the crux of what you're supposed to do. You can add some legumes in there, so that the beans and the food similar to that, and then on top of which, then you have a little bit of lean meat, so you can have some fish typically, and then more maybe have some lean meats, so sort of the animal meats, but a little bit of that, and then on top of that you can have your desserts and bit of dairy and so forth, all of which is your fat sources, extra virgin. Olive oil seems to be the best fat source in the Mediterranean diet, so you throw out the butters and
Right.
you add in the
No animal
EVOO,
fat. Yep.
exactly, and throw in maybe a little bit of wine, possibly red wine, in moderation, and then you have the Mediterranean diet. There's much more to that. I wrote a book on it. There's tons of stuff on the internet, tons of stuff that Alan has done. So I don't want to spend the time on the Mediterranean diet, but suffice it to say that is the one that not only keeps your weight down if you can follow it as best you can without living on the sort of the hills of Corsica in the 1920s before any industrialization. Outside of that, it's a difficult thing to actually do. It's an easy thing to say, difficult thing to do all the time.
Sure.
So there's a lot of tips and tricks, and that's really where I want to have Alan give us his overall thoughts on that, and then we'll talk more about exercise.
Great.
A couple of things that you were discussing. We want to mention visceral fat. That was never brought up yet. Visceral fat. So when Dr. Sofer was talking about the abdominal area, we're talking about visceral fat. This is the fat that surrounds the organs, and this is what leads to particularly what they call metabolic syndrome. And that metabolic syndrome is a different symptoms like high blood pressure, diabetes. They'll kind of fit into one big category. But when we're looking at people who are obese, and there's a lot of downsides because the fat cells produce cytokines, and these cytokines can really damage the body in many ways. But I think one thing we need to address. Go ahead.
So say more about a cytokine, because that's a vocabulary word.
These are chemicals that are just bad chemicals.
Okay.
That doesn't produce good things in the body.
Okay.
But I think the big problem today is as much as genetic that we see today, we have to look at the hormones play a tremendous role when it comes to weight gain and weight loss. We looked at ghrelin and leptin. Leptin produces by the fat cells. The leptin is what is your satiety hormone that makes you feel full to say no more. And ghrelin is the hormone to say, okay, I'm craving. Now, if you go back to the basics of what people eat today, in the boxed foods, that the majority of all foods in the supermarket, outside, we'll say that's not on the outside aisles because the outside aisles are the healthiest foods to eat. Everything inside the aisles are processed and refined in general, in the majority. Those foods are empty calories, a lot of these foods, because they've been refined. And what happens is the brain doesn't see it as something like, okay, it's healthy for me. So it craves more and your ghrelin levels go up and your leptin levels become more insensitive. So they go down. So I think hormones play a tremendous role. And the white sugar is very inflammatory. Going to looking at other things to, how do we increase metabolism? Because that's the big thing today. There are many different natural herbs. I mean, Doc knows all of, we talk about apple cider vinegar. You had a big thing you were telling me with WebMD, the things that you've learned in research, I think is a big thing. But the acetic acid has an effect on satiety. And I think that what we need to do is we need to learn how to eat correctly.
Sure.
Because I think that's the big downer today, that you got kids and people just eating foods that are just non-nutritional. I
mean, so there are broader forces at work here, even just in terms of the availability of healthy food. So, I have this conversation with my kids all the time, like why a head of broccoli is $3, but you can get a hamburger at McDonald's for $1. It's like if you have we may not have limited resources, but plenty of people have limited resources and limited time, and therefore that hamburger becomes super valuable to them. And the bun, for instance, reflects those empty calories, the same way described in the middle of the supermarket.
But I think there's so much education because it starts from the real basics that you don't have to spend a lot of money to eat healthy. It's just that you really need to spend knowledge to eat healthy.
Well, I've heard you say this before, where bad foods, we all agree bad foods can make you sick. Anyone saw that McDonald's thing where the guy ate stuff and he actually got sick because all he ate was McDonald's for a while?
Well, it supersized me. Did it for 30 days.
Right. So the opposite, though, is also true, and that's what a lot of his information on the internet's about, is that good foods can then make you healthy. If you believe bad foods can make you sick, it's not just the absence of bad foods, but actually there's good foods that can make you healthy. So he talked about something that I want to expound about for a second, which is inflammation. So inflammation, what does that mean? So in your bloodstream, you have these cells that are out there trying to repair stuff, and they kind of naturally will inflame an area as it's trying to fix it. So if you've got a lot of toxic foods coming in you, these cells are out. Well, it turns out that these cells don't just fix broken stuff. They actually set up something in the body that's dangerous. So when you have inflammation, we've found out now in my cardiovascular background, we knew years ago that if we check for inflammation, something simple like what's called a CRP or a C-reactive protein, it's an inflammatory marker. And we check for people that just have a CRP. Forget about anything else they have, diabetes, forget about a heart attack sign, nothing. Just look at the inflammation that's going on in their body. That is a separate risk factor for heart attack. So if you're eating stuff that causes your body to inflame a lot, you are going to have a risk for heart attack, stroke, high blood pressure, all those sorts of things. And there are foods that can reduce that inflammation. And what are some of your favorites? You talk about
anywhere from turmeric is extremely beneficial. Garlic, which not only has a nitric oxide that can actually cause vasodilation or increase blood supply.
Well documented.
So you got turmeric, ginger, great inflammatory. Believe it or not, black seed oil. Black seed oil is a really great natural anti-inflammatory.
So those to me, and I'm probably using the term incorrectly because I'm not a kitchen guy. Those seem more like condiments than food. So
Spices, herbs.
Right.
Correct. That's correct.
But from a food, like if I'm hungry and either I'm going to pass by the McDonald's or I'm going to run into Publix or a supermarket to get something, I can make a choice, right, to fill my belly with something. What's something that's going to satiate me? That's going to and I don't remember the name of the hormone, but what's going to fill me up?
Ghrelin.
Yeah.
Very, very simple. You want your soluble fibers. Your soluble fibers are your fruits and vegetables. Your
Okay.
apples, one of the best. Your pectin, one of the best soluble fibers you can put in your body. Why? Not only will it will satiate you, make you feel more satiated, but it slows down the digestion of the stomach into the small intestine. So therefore, what it not only does, it helps balance out sugar, glucose, your insulin, and your glucose levels, so you don't get that spike. Now we're looking right back at glycemic index. High glycemic index means it absorbs quick. Low glycemic index means it absorbs slow. The lower the glycemic index food, people should Google glycemic index foods, and they'll see all the foods that are low in glycemic index. Sugar being the highest, okay?
Right.
Grapefruit being one of the lowest as a fruit.
Right.
But the lower the glycemic index, the slower the absorption, which means the more balance.
So I think what he's, in answer to your question, Adam, what he's saying is, once you have inflammation, obviously, if you're causing it by eating the wrong foods, eat the right foods. So he's telling you the foods that are now the right foods, so
Sure.
low glycemic foods.
Your fruits and vegetables.
High fiber.
Correct. That's the key. The key is that it's okay to eat sugar.
Right.
If natural sugars, as long as there's fiber with it. So when you're eating processed sugars, that's where the damage is.
Okay.
Which
so
is
it's-
basically the Mediterranean diet,
Yeah.
the
Right.
base of the Mediterranean diet thing. Now, you were asking, well, what about this? You're talking about turmeric, for instance, which is a well-known anti-inflammatory. He's saying that if you already have the inflammation going on, you want to counter that, but you don't want to use, there aren't really a lot of good anti-inflammatory medications. There are, like Advil's an anti-inflammatory, but that has way too many side effects.
Right. They all carry risks.
Right.
So turmeric might be one of those answers where you can actually use that as kind of a silver bullet, if you will. Now, I don't want to say it like blanketly, but if you're going to add an anti-inflammatory thing that isn't a food, those are good foods, and they're being highly studied now
Yep.
by scientists from all over the world.
The curcumin is the main thing that we're looking at in the turmeric, that really orange color. But one of the great antioxidants that has so many different medical medicinal properties. But turmeric is definitely one of the largest. And if people Google turmeric today, tons of studies out there.
Totally
Tons.
get it. I'm a food monkey. I'm not advanced. So what would I put it on?
Oh, you
I don't even know what it tastes like.
sprinkle on your vegetables. You could put it on anything. Stews, you could do it on anything. Some people,
So
actually.
it's more savory than sweet, though, right? Is it?
Yeah,
Okay.
yeah, not sweet, but there were other things within the turmeric group, which, you look at even peppers, like your cayenne pepper, your chili peppers. Those are great metabolic inducers, but again, they're great natural inflammatories too. Okay, so there's that whole category of those
Right.
spices are actually.
But I think the key here is not to have the inflammation in the first place.
That's correct.
So if you're eating that low glycemic, high fiber diet,
That's correct.
You're not going to need those things. We're saying those are good things as anti-inflammatories.
Right.
But if you have ongoing inflammation, it's usually a longer term thing, and those that are brought in by foods or by eating the wrong foods.
Sure.
I think we stated that rather than focus on an antidote that you might need periodically. They're just nice to have.
I mean, you talk about the Mediterranean diet. One of the greatest things in the world, extra virgin olive oil, one of the greatest natural anti-inflammatories.
Right. So the second thing that you had mentioned was, one was the hormonal component and ensuring you're full, or that something isn't somehow tamped down so you don't feel the opportunity to be full. But then you also talked about increasing metabolism or the metabolic rate. So are there foods out there that might help you burn through your calories a little bit quicker? Or?
My favorite's cayenne pepper. It's
Okay.
up on the list. Has a lot of good thermogenic effects, thermogenesis. And one of my other.
You mean it makes you sweat when you eat it?
It could, but it would
Well,
definitely.
it definitely makes me
it will
sweat.
kick it up. But one of the finest teas is green tea. It has catechins in here. It has epigallocatechin gallate, if I said that right, Doc. That is one of the finest things that you can have for metabolism. And the green tea, matcha tea, is even probably a little better. But the green tea, not only that, but there's so many strong powerful antioxidants.
Okay.
I mean, realistically, I think the way people need to look at things, what are antioxidants? We're always having these free radicals. The free radicals, for example, you put a key in a lock and leave it out, it's going to start to rust. That's what's happening in our body. So we need these antioxidants to kind of fight that, to keep our body from rusting. And basically, these antioxidants cause inflammation. So every disease, and Dr. Sofer can tell you, every disease, particularly cardiovascular disease, before it was so big with cholesterol, we still want to make sure LDLs are at normal levels and everything else, but it's the inflammation, it's the white blood cells that start attacking the lumen of the internal part of the arteries. And as that attack is going on, you have these LDLs coming through and these different minerals coming through that start to cause sticking and plaquing and all kinds of stuff. It's the inflammation inflammation is tied into diabetes, it's tied into cancer, it's tied into every disease known to man. It doesn't matter what the disease is called. It's inflammation. So how do we prevent the inflammation? That's the key. Inflammation is tied into obesity.
Right.
I mean, because there are inflammatory markers in obesity. Those are the cytokines. So.
Yeah, so I remember in one of our segments we did, I think live, we talked about the extra virgin olive oil kind of being the lube, if you will, of the circulatory system.
Right.
So if you get enough of that in you, you will have less of the effects of inflammation. So it's a super duper consideration and will help, again, with being overweight. So if you follow the Mediterranean diet, you're going to be less. Now, that being said, it's not just diet. Let's maybe go on to the segment of exercise, which
Absolutely.
Which Dr. Mandel's also an expert on. You were going to ask.
Well, I think there was this is a multivariable equation we're trying to solve for obesity, and there are some things which we can definitely talk through and kind of have this linear effect of, hey, don't eat that, eat this, or add this to whatever it is you're eating, or avoid these things. But there's also the very real situation of, I don't know if it's Newton's first law. I'm going to say it is. Body at rest tends to stay at rest. So, let's talk a little bit about exercise and how that has an effect on the obesity and just the general wellness component we're talking about here.
I think you have a double whammy sword here. You got someone that's really obese, that's carrying a lot of weight, that has bad knees, bad hips, bad back. They have problems exercising. So.
Right.
The question is, what is the best exercise? There is no best exercise. You got to do what's best for that person. I think that's the most fairest statement.
Sure.
On the other hand, one of the finest and greatest things we can do for our body is build lean body mass, lean body muscle, which is muscle, a lean body. And one of the worst things we can do when someone's trying to lose weight is just lose weight and do nothing, because obviously you're going to start losing muscle,
right.
Particularly those that don't supplement well with enough protein in their diet. But I think that if we just concentrate of taking a band or doing specific walking or whatever exercise it is to at least maintain muscle, because maintaining muscle has an increased thermogenic effect where it increases more calories at rest than it does if you don't have muscle. And the problem is, as we get older, we lose lean
muscle.
body weight.
Sure.
So I think we need to focus more on lean body weight as we get older, because I think that's the big problem why people gain weight, because we're losing too much muscle.
I've heard about the difference between the aerobic exercise versus weight training exercise that used to be much heavier towards the aerobic exercise. Now I think it's in the science about a 50-50.
It's changed.
So you got to got to have
I
both.
agree.
Yeah.
I agree.
And weight training has to be, and there's a lot of interesting things. I was reading in a very interesting article where it talked about how those who did a certain amount of weightlifting did better with things like coronavirus, things like pneumonia, because as you build, for instance, your chest muscles, it helps you to expand when you breathe and inflate and deflate. And if you do that, you keep the bronchioles, the air sacs, open longer and stronger. So by doing something as odd, if you would, as doing push-ups or maybe getting on a weight bench or something like that, or maybe even better like lat pulls where you're expanding your rib cage.
Yeah.
Those kind of things actually have effects from a general health perspective that we didn't really realize. I read a study that was a summary study, 786 combined studies out there that was done in the British Medical Journal, I believe it was, that talked about, all of these studies talked about high intensity
High intensity interval
training.
Excellent. Very good.
So it seems to be like that may be.
Do you think they had to do 786? Like at some point, did
That's
maybe
all
haven't?
within the last 5 years. You're
Right,
hearing more about
right.
this stuff than you ever have in the past.
Right.
But one very important thing is cortisol. Cortisol is highest in the morning, lowest at night. That's the kind of time we go to sleep when we look at our sleep-wake cycle. But on the other hand, Doc, when
Wait, what does cortisol do?
cortisol helps with inflammation. It does a lot of good things, but excessive cortisol is where the problem is.
Okay.
Too much cortisol goes directly with fat. It's a fat.
So you had said it's highest in the morning. What do you want to do then, as it relates?
The reason why it's highest is because that's when it allows our brain to focus. That's what sets us up for energy to proceed within our day. And as it goes lower, that's the time we go to sleep.
Right.
So we don't want to increase high cortisol levels before we go to bed. That can throw us off, and that can actually make us more fatter, because when you don't get proper sleep, it increases ghrelin. So when you increase ghrelin, people are going to eat more.
That's for the I'm hungry or I can't be.
Exactly.
Okay.
That's why people overeat when they're overtired,
Right.
which can increase weight. The other thing is cortisol. Doc, when people are over-exercising, that's why you always like moderation. Too much exercise is no good. It's too much cortisol. So that goes a little bit deeper physiology.
But that's a brilliant point, because the out of those two studies, the one that stood out to me was this guy, also out of, I think it was out of Canada, the Royal Canadian Air Force guy, Bill something, Bill Orban or something, wrote an article that says 11 minutes is all you need. And it wasn't just him writing a singular article. He had done research on those folks.
11 minutes of what? Exercise?
Of high intensity interval.
Total.
So basically, like, burpees and sort of jumping squats,
Yeah,
things like that.
compound
Right.
movements.
So they're increasing your heart rate. They're increasing the intensity that you're doing exercise for. Also working your muscles. It's not like a long, slow run.
Correct.
And he came up with the number 11 minutes. Whether or not that will sustain over time, I'm not sure. But I can tell you, within those folks and within that study, look it up, it showed a fantastic improvement in weight loss.
Yeah, absolutely. Yeah.
So I think you're right. Less is probably more. Intense is better than non-intense, with combinations
And
of
that was
intervals.
per day?
That was, I think 3 to 5 times per
Okay.
week. So anyways, those are the things that we keep reading about that become more and more true. 3 to 5 times per week of probably under 30 minutes of higher intensity with interval training. So exercise, stop, or run then walk,
Right.
Walk then run. You do that kind of thing with a little bit of weights. I think that's all you're going to need, and that's not hard to do because it could be under 30 minutes.
One last thing I wanted to mention, I think, towards that weight gain, that satiety. When most people feel hungry, they're not necessarily hungry, okay, because the way the brain is trained. So sometimes it's drinking a glass of water 15, 20 minutes before you're about to eat can sometimes give you that satiety back again.
Right.
So for people trying to lose weight, by adding more water, because I think the majority of the world is dehydrated, we don't drink enough water. I think that can be one of the reasons why we feel this crave to eat. We're not really hungry, we're just really thirsty.
Right.
Interesting. I definitely have advised the patients through the years more water, but I think the timing is probably
the
crucial,
timing.
and that's something that you say, 30 minutes before you eat?
About 20 or so
20,
minutes
30 minutes before you eat.
before a meal. Yeah.
Great information for everybody out there. So with that, I think I'm going to go on to some of the, once you've exhausted all of the, the basic nutritional remedies and then the exercise remedies, then comes, do you need to be supplemented by medications if you've already become overweight or obese? But before I go into that, is there anything you wanted to summarize on, Alan, or?
No, I think we covered the highlights of it. Yeah, there's a lot of things you can really go deeper into, and I think that could be for a different type of program. But I think the most important thing, in summary, if you really want to lose weight, you must have your fiber, because your fiber, you need that satiating feeling. You need to regulate. Remember, when your blood sugar levels are off, your glucose is off, your insulin is off, it's going to really throw off your hormones. That's the key. The key is sustaining proper balance, that homeostasis within your body, and that's going to actually help someone achieve their goals.
And then if you have the right fiber, you have the right gut biome.
That's
the
correct.
Gut bacteria.
That's correct, because fiber, great point, Doc, any fiber is what we call prebiotic. and you have probiotics in your gut. And 70% of your gut is your immune system, okay? So we all have heard the gut-brain connection. There's a gut-brain connection because your gut, as they say, is your second brain. So yeah, you need to feed those probiotics to keep healthy. And by feeding those probiotics, it's going to increase your satiety.
I think what Dr. Mandel described earlier is the non-clinical definition of hangry is what I heard him say, is that when things aren't right, your brain's not clicking correctly, and you just grab the first thing and
it's a
jam
brain
it.
it's a brain disorder.
Got it.
But it's a hormonal brain disorder. But Doc, I appreciate everything. It's a great material, and I'm really looking forward to your other specialists. These are renowned John Hopkins surgeons, and I'm going to just stick around. I want to hear what they have to say. I'm excited to hear what they have to say. And I also want to say one thing is that, listen, that's why we have different professions out there, because when certain things don't work, what do? Well, thank God we have these other people that can make progress and make positive changes in the world. So we want to thank these great people for the knowledge and the things that they do as well.
Well, I know you are famously unable to take a compliment, Alan, but I will tell you that you've inspired me to do all of this. We met sort of socially, and in the end, you can affect so many people in front of you, but when you master understanding how to communicate to others with all of the digital and social media capacity that you've, begun to figure out, you've really changed the world a bit. And your viewpoint is so, I think Adam would probably agree with, it's so understandable, so humane. Your heart comes out when you speak. You speak very much from your heart. You speak from a point of view that a lot of people can relate to. I know I can. I know a lot of our viewers do, and I really appreciate all that you do for the countless people that watch you, that follow you, and you've inspired myself and these others. If it wasn't for you, not guys like you, specifically you, if it wasn't for you, we wouldn't all be in this room doing what we do. So. Thank you very much for coming today.
Thank you, and listen, your heart is not too far from mine, so you've also got a huge heart, and thank you too as well.
Thanks.
And thank you for keeping us together here today.
You bet, anytime. Thank
right.
you. So we had a great conversation with Dr. Mandel, and we walked through a progression of obesity, what the definition of obesity is, and what some of the main interventions are, which are diet and exercise. And there may be circumstances where that's not enough. There's a lot of medications that are on the market, a lot of them being advertised right now. Why don't you talk through a little bit about what those medications are and how they fit into the broader scheme of things?
Yeah, so it is an exciting time in terms of medications, right? So first, it's obviously diet and exercise education, first and foremost for being overweight or obese. Then comes the consideration for medications. There are only 5 real medications or categories of medications, really, limited, that have been FDA approved. Lots of stuff out there. 5 that really are used right now, and that is kind of a big deal because for high blood pressure, I don't know how many, but I know of like 30 of them. There's a lot more, so it's a difficult thing to do. Most of them come from side effects for medications that were built for other reasons. So the first category I'll sort of mention is this phentermine, and medication that we call topiramate, which came from a completely different field. The phentermine is kind of the Adipex, that kind of it's an amphetamine.
Okay.
It's a light amphetamine, and it's used often by itself to cause less hunger and therefore some weight loss that comes with it. It's indicated for about 3 months, and then you're supposed to come off of it, and it shouldn't be a long-term
And
medication.
amphetamines just basically kind of ramp you up your metabolism, your heart rate, and that's what they do.
Yes.
Okay.
So it comes with a mixture of another medications that was used, for things like headache and so forth. And the combination seems to be useful because you can use a little bit less of each and get a decent result, maybe not be as amped. And yet we've not seen the greatest of great results there. So You're talking about probably around a 5% weight loss over time and a host of side effects that make it okay, but probably not my first choice. Qsymia is the brand name. And the 2 drugs are what I mentioned. So that's one sort of category, one type of medication. The next one is called Xenical. You may have heard about it. The one that, they do a lot of TV advertisement, but kind of lose a lot of people when they say, you might have loose stool with it because it acts in a different way. It's not amping you up. It's actually absorbing some of the food and having the calories, about 20-30% of your calories, be kind of pooped out.
Right.
But the problem is it overwhelms the bacteria and the gut itself a little bit, and therefore diarrhea and diarrhea-like things, leakage that they make fun of a little bit, is one of the issues with this orlistat or Xenical. So another route, it can be helpful in some people. However, it does have some side effects. And again, it's about 5% of your body weight in 3 months. The next category is this interesting combination of naltrexone, which is used to stop drinkers from drinking because it makes you feel a little bit ill, and bupropion, which is actually yet another one of these combination medications. The whole thing is called Contrave, and that is working on the brain, right? So you're really having...
So we got one that's basically working on your engine, one that's working on your gut, and now one that's working on your brain.
Exactly correctly.
Okay.
And you would think the biggest issue with the one with the brain can be stuff like insomnia or depression.
Right.
So don't love that conceptually. Have used it periodically, and it does work, but again, not the bigger weight loss that people are looking for, particularly by the time they're obese. So then come these new types of medication. There's two categories. One is called Saxenda, which is a sort of a shorter acting version of what is more commonly used, which is called Wegovy or Ozempic.
Okay.
Which we hear a lot about lately. And that's
Well,
the
they're
longer
advertising like crazy.
Right. It's the longer form of semaglutide, which semaglutide is the longer form that's used in Ozempic versus the older one that's used more in children, the Saxenda, which is basically...
You realize you're saying sex ender, right? Which if this was a show all about New Yorkers, you'd be like, that's a sex ender. That'll be it.
Yeah, I don't know.
We're done. Okay. Anyway, so the Ozempic.
I've got to be a little more articulate. Yes, the Ozempic works really by it's an insulin agonist. So bottom line is it makes your gut motility move a little bit slower and make you therefore a little less hungry. And the nice thing about it, and maybe the revolutionary thing about it, is you can take one shot once a week, and it seems to
So it slows. It sounds like you said it slows your digestion. I'm going to cut you off, but the convenience aspect is much better because it's one shot a week, is what it sounds like.
Yes, and it makes you a little less hungry, able to kind of push half the food away. You don't have to constantly think about it every day. The side effects are pretty low. So we've seen a little bit of nausea in the first few days, but if you sort of go at a low dose and go up on the injections, once a week, sort of a painless injection with this little pen, it seems to be very, very useful. I've seen it used countless times in many patients with terrific results and much higher. So you can see about a 10% or greater body weight reduction. So if you weigh 200, you could, easily someone, losing 20 to more pounds, which is a little more than just losing, 5 to 10 pounds.
Right.
If you're 300, you could see 60-pound weight loss, and it's sustainable. So as long as you can keep the injections going, that seems to be very, very useful. It was used in diabetes. So the fact that it's used for something you may get anyways, and it seems to maybe stave off diabetes by getting you to lose the weight, it may be the drug that as physicians we've been looking for. And I got to tell you, from my perspective, it's the first one that really excites me, and I'm seriously thinking about it. And not just, by the way, for patients. I've, through the COVID-19, I've gained my weight. And
you put on the COVID-19.
I put on the COVID number 19 pounds, and I'm doing the best I can, but I've, gone up and down a little bit, and as you get older, it gets a little harder and a little slower. And I have diabetes in my family, so I am seriously considering it, and if so, I'll do it for all the viewers in a way that everyone can see it. But I can tell you, people in my office have done it with tremendous success.
So, you ran right past it, but it sounds like, and I just wanted to be able to say this word, it has a little bit of a prophylactic effect on type 2 diabetes. Is that what you're saying? That it staves? You said it staves off. So
well, it has you reduce weight. We know that weight loss has a prophylactic effect.
Okay. Cool. So those are the drugs. If I were to summarize it, all of them have some sort of shortcoming, except perhaps Ozempic as a brand, right? There's
and just came out about 3 to 6 months ago. There's two. There's Wegovy and Ozempic, and those are the two that came out. They're basically the same medication, and they're expensive.
Yep.
and they're not covered by insurance, and that's a problem. So there's going to be, sort of weight loss centers are going to figure out how to do it, and, maybe figure out ways of doing it more cost efficiently. I'm not sure how that's all going to work out. Hopefully insurance will cover it, because why wouldn't they cover it? They're going to pay for all the ravages of obesity if they don't. So I would hope that they do at some point. Maybe they'll put a level. Maybe it has to be a BMI of 30. Right now there are some levels like that, but this is actually useful just for weight loss. You don't have to have a disease with it. Usually the drugs are covered if you have, obesity plus a disease. Now it's just obesity with those two drugs. So it's exciting stuff. It's the new frontier, I think, of medication for weight loss, and I'm very hopeful that this is going to make a big difference for a lot of people. And those that aren't there, and there will be plenty that still need something more, that's where we're going to get into the need for surgery, which is also making its advancements. And that has its place, and it's a tremendous place. And maybe in combination with medications in a lot of ways, maybe that will be a bit of the answer that we're all looking for to reduce this epidemic. And for that reason, let me segue real quickly. We have my esteemed colleague, Dr. Donald Waldrop, who has joined us fresh from Beverly Hills, where he flew in last night to be in this segment, and I appreciate you flying in, Don. And Don is a bariatric surgeon extraordinaire. He actually had a procedure named after him. He finished Cedars-Sinai with me, I might add, 30-something years ago, many years ago, and has, in California, really made quite a mark in the bariatric surgical world, if not internationally, where he's internationally recognized. So I really appreciate you coming in and being with us in this sort of weight loss summary episode, which is a fun thing for us to do. And maybe you can give us your take on the state of the art of surgery for obesity.
Well, thank you for sending that plane, by the way. So it's very nice of you. And bariatrics, I've seen it in an interesting arc. I kind of was there at the beginning of the rebirth of bariatric surgery with minimally invasive technique, where it got much more attractive to the patient and the physician to recommend it. And so we saw several techniques kind of come up. Every technique, like you talked about medicine, every technique is going to be the perfect thing. Then something happens or some outcomes come out. Then it's the worst thing. You wouldn't do it for your dog. Then it kind of comes, it's in the background as a tool. And so, I saw the huge popularity of bariatrics when it first came out, because it answered such a problem for so many people. And now I think it's fairly acceptable. I think people know it's available. I think it's there's much more highly trained surgeons out there across the nation doing it, and I think it's perceived as a very reliable therapy for people that really need to control their weight.
So a patient, you eventually get a patient, they've probably gone through this progression of, or maybe incapable of, depending on the state of their body, of the diet and exercise, some of these drugs. Maybe these drugs are happening in parallel with the pre or post surgery state. How do you work with a patient to determine the best approach? And I'm asking this as I don't know if there are 18 different ways to provide these bariatric surgical procedures, or if there's only really two now. But kind of talk through why one would be appropriate for one patient but not for another patient, or vice versa, so you can get a little bit of a flavor about what actually happens. And if you could describe what actually happens, I think that for a pedestrian, we've, and I'm going to use air quotes here, stomach stapling, a lot of old terminology that's out there. So maybe you might be able to demystify, what actually happens and, the mechanical and physical effects of all that.
So that was a great question.
Thank you.
I'm not just saying that. I'm just repeating it. Well, that's a great question, because what's available now in bariatric surgery is a lot of very different kinds of procedures. You can have inpatient procedures, you can have outpatient procedures, you can have some that are very aggressive and some that are less aggressive. And on it, like any menu, not everybody wants everything on it. And you're right, by the time people come to surgery, they've already been through one or many different experiences in an attempt to weight loss. And that's kind of the subtext of what I think I hear most commonly in my practice. Kind of two questions. Why am I here? And did I fail? So why am I here? How did I get to the point in my life where I needed to see a surgeon to be able to lose weight? Because all my skinny friends give me all this free advice on what I should do. And as you talked about today, it's a very complicated picture of what we understand about weight gain, how to control it, maintain it, etc. And the other question is, am I failing? Do I fail? Because they feel like, or made to feel like, they failed everything they've tried, calorie restriction, medications, or they have side effects, or it doesn't work for them, or as well, or as long as they wanted to, or they're not able to exercise because of their weight or pain or anything else. So it's a fascinating spectrum of what we see. There's a game show nowadays where they don't see who's singing, right? They turn around, and I think if you took my lightest patient and my heaviest patient and heard their stories, but you weren't seeing them, you find them remarkably similar. Frustration, pain, anxiety, self-esteem issues, goals even. They're not necessarily negative, but they want to be off of medication. They want to be able to roll around the floor with their grandchildren, or things that we
take for granted.
Yeah, thinner people or less heavy people kind of take for granted. So that's part of the story that we hear, and surgery is part of our workup. We want to understand what a patient's basis has been, and also for me it's more important, do they have a realistic expectation of what surgery is? And I think the way it's sold a lot of times when patients come to me is they think they wake up in the recovery room with a big cardboard check and confetti and paparazzi, and they weigh 110 pounds, and surgery is just some magical thing. And it's not too overused in surgery circles that we say weight loss surgery is just a tool. And it is a tool, and it's no different than everything else you've talked about today. And so we say, you can't build a house without a hammer, but you also can't build a house with just a hammer. So surgery works remarkably well for weight loss, and maybe better than most things, obviously. But when you use everything in combination, realistically and reasonably, you optimize each of them together. So that's what really we want to know about patients. What's their mindset about their expectations and what they are able to do.
So, and I may not be able to characterize a typical patient. A patient, male, 40s or 50s, 400 pounds, let's say. They've done all that stuff. Is there a tried and true approach, from a surgical intervention standpoint that you typically is your go-to that has a high success rate, obviously, from a surgical standpoint, but then the outcomes are in X number of weeks, days, or months, or whatever the time frame is. It's about expectation setting. Yeah, the confetti. Okay, so we forget about that for a second, but in 3 or 6 months, when surgery's in the rearview mirror, how do you set up the expectations? And maybe you could talk through about what a typical patient might experience from a timeline standpoint.
Well, another great question. So again, you have an array of what we can offer a patient. I really almost always let the patient decide what they're going to have, and there's a lot of reasons for that. One, they have an attraction to a surgery for some reason. One looks more aggressive. When you show a patient a gastric bypass, for example, it's a convoluted picture. The actual picture of it. You make a small stomach, you separate the stomach, you have to reroute the intestine. There's a rerouting, there's a reconnection. As opposed to something like plication, where you just simply fold the stomach, or a sleeve where you take off most of the stomach and you leave a sleeve. So sometimes people are attracted to their ability to connect with their understanding of it.
Okay.
Or their perceived benefits of it, whatever they do. There are rare cases where a patient shouldn't have a kind of surgery based on their medical history or past surgical history or some other reason. Those are relatively easy to pick out. But mostly I let people pick their surgery.
What do people usually pick?
For my practice, they usually pick plication. So in a plication, we just free up the left half of the stomach and fold it in on itself just with sutures. So there's no division of the intestine, there's no rearranging, there's no device like a gastric band. So a lot of patients like that because I think it's the simplest idea for them.
And literally you make the stomach smaller.
Smaller. So that's the one combination of the one common trait of all the procedures. They make the stomach smaller or seem smaller to your brain.
Okay.
So the stomach is still there. All we've done is change the shape of it so it holds less food. And that's kind of the first common denominator of every surgery. Even a balloon that we do, an intragastric balloon, which takes up space and provides some weight, so there's some idea of fullness, and it slows down emptying. So the idea that the stomach only needs so much food, not as much as it used to. And So they all work on that kind of degree. And then the common denominator for life after that, to put it simply in the time we have, is I leave people two tools. For when they're in food situations, which is now it's so common, right? We can't get away from food. Is, do you really need it? Is it an opportunity for nutrition?
Right.
You need to make time for it and think about it, not take it on the fly or quickly, or eat worse food, I guess. But or do you really want it? Are you in a situation where it's time you want to eat more food or something decadent or something else? But you just have to make up that math in another column, and because calories, I really tell them this kind of crystallizes it for them. Calories are not snowballs. So you don't see calories. If you don't eat that piece of cheesecake, you're not going to lose that kind of weight. I think that's how most people look at that scenario.
Wait, say that again. If you don't see that piece of cheesecake,
if you don't eat that, you've taken care of that weight in some
right.
way. And it's more, calories are really humidity, not snowballs. They waft around. The amount of calories that it takes to add weight over time is remarkably low. And that's another reason people come to me and say, how did I get to this point? I don't think I eat more than my family or friends.
Right.
And a lot of times they don't. And I used to have a very complicated slide based on some research, but it shows if you take a half of 1% of what you need. So you're going to get up, you're going to work here today, you're going to get up, you're going to go to your car, you're going to go, whatever you do, all that movement is going to be a certain amount of calories. So in a year, 1 million calories in flux. If you take 1/2 of 1% more than you need to do that, that can be 50 to 100 pound weight gain in 10 years. And so when patients come to me and they think back, well, I don't eat that much. And we used to think, early in my career, I'd say, well, they probably just don't get it. Everybody thinks the overweight person comes back from the buffet bar with a pyramid of food and things like that, but it's actually not that true. And you talked about metabolism, so I don't want to reroute and replay all that, but there's a big variety in that.
Okay.
So if you're taking, you're trying to remember, did I take 100 or 200 extra calories a day? And they think back on a month, you don't see that nowadays because you biggie size when you're in fast food or you're at work. You grab some candy out of a machine or something.
Or it's COVID-19. I mean, you're working at home, right, and everything is so accessible to you. Mm-hmm. So it's so easy to add that 1/2 of 1% for some period of time, and that is the difference maker. Is what you're saying is that. Yeah. The metaphor that I would use is in terms of problem solving, maybe even marital problem solving, is it didn't take you a minute to get into this problem. It's not going to take you a minute to get out of the problem, right? Exactly. I mean, there's probably an equal slope on either side. So let's go back to this imaginary human who comes in. I don't remember the technical term, so I'm just going to say that you've made their stomach in half. You've shrunk their stomach. And they follow your generally prescribed activities, which is to consume a little less than you need, or to even out your caloric intake with your caloric output, et cetera. What are their expectations? All things being equal over time. What's a typical outcome? Is it a year that they go from 400 pounds to 300 to 250 to?
Well, it depends. Also, I don't want to get too mixed up here. So that was a great question. So weight loss, the way we traditionally measure weight loss in surgery is you measure the loss of the extra body weight.
Okay.
So you don't want to lose your ideal body weight because that's the weight that's you.
Right.
So, and then people sometimes freak out a little bit when they see their ideal body weight. It's always some number they can't even imagine. And it usually is it's too low for what patients want to understand about it. And they think the word ideal means they should be weighing that.
Right.
And so it's a very lean weight. But I remind patients, we're just using that number to have something to measure to. It's not important what that number is or how close they get to it or shave it. And so we measure the loss of everything above that weight. So the more aggressive an operation like gastric bypass, the more you'll lose. Or the lower your body mass index is, and the more you're likely to lose a percentage of that. So it gets a little confusing because you might lose a much more higher number the larger you are, but percentage-wise it might be less. But a gastric bypass, so in a gastric bypass, again, we separate the stomach into two pieces, a small pouch and the rest of the stomach, and then we bypass a large part of the rest of the stomach and about 5 feet of intestine. So through a variety of ways, you ate less and you absorbed less calories. And that's about 80% weight loss, usually in a year. So for every 100 pounds you want to lose, you can lose about 80
of it.
pounds.
Okay.
And it's remarkable to witness it and to be part of it. And because when I got into bariatrics, I thought, well, maybe by the time I retire, I'll see the fruits of my labor and it'll be interesting. But you see it so quickly.
Really?
Yeah, and patients are so grateful and their lives are changed. It's amazing.
So I don't know why I'm stuck on this imaginary person, but I'm trying to make it real. So this 400-pound person, let's say that their ideal weight's 200 pounds, right? I'm not trying to be a Pollyanna about this.
No,
so
make it easy math.
In a period of time, they could lose 80% of the 200 pounds extra. So they could lose 160 pounds is what you're saying because of the gastric bypass? Like, is that what you're saying?
Yeah.
Okay, so the rest of the remaining 20%, which in this case is 40 pounds, if I'm keeping the math correct here, they still have to do all the other things, right? Like there's no, maybe a terrible metaphor for the topic, but there's no free lunch. You just can't lean back and it happens, right?
Too much free lunch.
Too much free lunch.
So
thank you.
I'll tell you an interesting statistic. We're talking about how it's hard to get away from food. In the year 2000, the percentage of overfed people on the planet surpassed the amount of underfed people. So what's interesting is we all have a common compassion, right, to feed the hungry and make sure people have food. But we're getting into an era where we're going to have to think about how is food going to be restricted from having. Food's now scientifically designed. It's enjoyable, it's attractive, it's certain colors,
it's awesome.
Advertising.
Yeah.
The chemicals just to make it smell a certain way, advertising at night to get it in your head. So it's a gastric bypass is a good example where people can really separate themselves from that because most people, in 90% of gastric bypass, they completely lose interest in food. They're not attracted to the smell, the taste. They may have their thing they grew up on that was their favorite food and it just isn't right
Turns
anymore.
them off.
But that will change over time. So we'll lead back into your question about how do you prepare people for the long term.
Right.
Then it becomes boring. When you get down to the last 40 pounds or whatever it is, it's the boring part.
Yeah.
I always show patients a weight loss curve over time and show them the exciting thrill ride, where it plummets down, the roller coaster ride. And then there's this long, as you get closer to your ideal body weight, there's the long, slow part. And when you have surgery at a lower weight, you're kind of left with just that slow part. So you really, that's why you have to recommend, the commitment and the other tools in the tool.
But they also have to realize, because as a cardiologist, I can't tell you how many patients of years in the past and now that we're on different coasts, the folks in the other parts of the country that do bariatric surgery, and the patients come in to see me and their diabetes is gone, their high blood pressure is gone, their cholesterol is all of a sudden perfected, and they're off medications for those things.
Right.
So luckily, most doctors don't have any stock, if you will, in medications, but they are coming off medications at such a rate that even if you keep that extra 40 pounds, or you gain back even a third of it,
right,
which I think can happen, they still almost never go back on the medications.
Yeah, you've tilted back a lot of those dominoes that had fallen before.
Which is about as close to a fountain of youth, if you will, that we can actually have. So it's a great tool, as you said. I think it's a great word. You're quite a tool. To come out wrong, but your tool, as I've seen what it's done. And it's we've all seen it. We've seen it on celebrities. We've seen it,
Sure. Well, I think and that's maybe part of the romance of the confetti and the big check is we've had shows like The Biggest Loser, right? So there's this big reveal, and those shows obviously have compressed weeks, months, maybe even years of all that work into a snapshot, and obviously that's not the reality. Which is why I asked, the media component of food presentation and marketing. I mean, there is a media component of weight loss and all this instantaneous stuff. So that's why I wanted to ensure we at least saluted that there is no free lunch. There's still hard work to do, and if you got yourself in a position over a certain period of time, expect a similar period of time to get out of the problem.
Yeah, and that's actually one of the things I ask my patients very clearly to understand, and it's actually on the material show patients, is don't over-idealize, but don't underestimate.
Right.
And you're right, it's oversold. And you go on The Biggest Loser, they're fairly anti-surgery, but you don't have to have surgery if you take somebody and isolate them for 6 months and control every part of their life. You take them out of their stressors of their family and their job and their traffic and everything else, and you put them on a camp. You can get great results.
Sure.
And then for
but
how
is
long?
is it sustainable?
But what's remarkable is that I see is that I can't tell you how many times I've heard, I've lost X amount. If I don't lose another pound, it doesn't matter to me, because those patients that I get to work with that have the privilege of working with, get somewhere they never believed
Right.
would ever be possible. So they lose 100 pounds and they have 60 more to lose, make up some number. They don't care because they're off medication.
Right.
They have their
mobility is
mobility
up.
back. Maybe their self-esteem, whatever their other issues were, or their sense of achievement.
Right.
They've done it. And there's always people that want to say surgery is cheating, and I don't think surgery is cheating in cancer. I don't think air conditioning is cheating. I don't think antibiotics or automobiles are cheating.
Right.
I think all these advancements that we have to make our quality of life, and that's really, I guess, where my foundation comes
Yeah,
from.
and I think if you run that to its illogical conclusion, like I don't think anyone plans to overeat or to not pay attention for 40 or 50 years, and I'm like, okay, I'm going to go get surgery and fix it all. So it definitely, that's why I'm glad we did this through the appropriate progression of, well, let's start with never being in that position, and then if you begin to be in that position, here's how we're mitigating it. And sometimes nature or God has other plans for you, and that you might wind up with you. I'm wondering, the patient loses that 100 pounds, they feel great about it, whether they lose the last 60 or whatever the case might be. But when they first come see you, I mean, do you find that a lot of them are also getting counseling, or you had said, have I given up or have I failed? Like, those are really heady issues that, as a physician, you're ultimately going to be dealing with the true physicality of the patient, right. But a lot of the stuff that happened is above the neck, and I'm just wondering, as you've matured in your practice, how you might see a parallel between the good work that you're doing and what someone else might have to do to help someone be comfortable with showing up to see you to take care of their problem.
Yeah, that's a real concern. And when I started in weight loss surgery, there was a big component about, I think, a bias actually against overweight or obese patients. And the feeling, and this is my crystallization over many years, is that there was a feeling that, well, there must be something wrong. These people are so overweight. There was an idea that, for example, most of our patients are women, and probably societally, because women are supposed to be more mindful of their weight.
Right.
Guys are just guys, right? So,
right.
That there was a higher abuse rate of some kind of abuse in their history, and they must be hiding it. And that certainly exists, but it exists across the population, unfortunately. In my reading of the literature over the years, and then you see the weight loss, the BMI charts over the years, climbing incredibly. I don't feel like it's based in that, but there's certainly patients who either have an etiology of some psychological issue that may participate in their weight gain, but also what I see is more with weight loss. And weight loss, people often become different, almost always they're positive stories about what they accomplished,
right.
Do, express, exercise, what they accomplished that they felt burdened by. There's kind of a saying in bariatrics: the larger you are, the more invisible you are.
Right.
Because you just kind of wallflower, and those patients don't want to participate and be highlighted. And when they lose that, they are expressing themselves, but sometimes, and it's not often, but they really get antagonized for that. Their spouse expects them to be someone different.
Right.
Or the people at work, hold it against them because, for whatever reason, you can imagine.
Right. I'm going to the gym 2 hours a day, and you went and you got your stomach
stapled,
stapled,
cheap
right?
Thing, right. You're getting more attention, whatever it is. I've seen these.
Yeah.
They're rare, but they do happen. They're very real, and some of it's my coffee book psychology.
Sure.
But you do prepare people. Sometimes it used to be, for me, much more mandatory, and certainly insurance companies typically require that if people go through insurance. I'm more selective about it now because I've participated with 10,000 patients, and
right.
I feel like I have a feel for who wants it and needs
right.
it, and it's going to get something out of it.
I have it's germane, but it's not about surgery. Noom, I had mentioned before about Ozempic being advertised a lot. Noom may be advertised as frequently, and I don't pretend to know all the inner workings of it, but I do know that there's a component of inspiration related to behavior change, not just compliance, which compliance sucks for people, but inspiration, all of a sudden now you're in control of what you're doing versus some other one, mandating to or not to eat something. Do you have a perspective on the efficacy or value of Noom and the or Noom-like apps in the greater scheme of things?
Well, I can't talk specifically about that plan, but typically, it's inspiration, motivation, any product like that, and most studies will show that people. But to me, it's self-defining that people participate in X do better, and I think that's a bigger aspect of health in general, and probably for everything in humankind success,
right.
Which is the more you keep something in front of you, your goal in front of you, the more you're likely to remind yourself of what your goal is. So in bariatrics, people that weigh themselves every day, sometimes it makes them neurotic about their weight, but they're doing something that reminds them what their goal is, right? People that run every day, set something up and they're getting ready, they're stretching, or whatever they're doing.
Just reminded me of a boss I had. She would travel with a bathroom scale. And she was tiny too, but she was neurotic about her weight. So I'm sure she was the percentage of patients who had something in their past, but and at the time I happened to work for a division of Sunbeam where we produced bathroom scales, so she had her pick of the litter, but she would put a bathroom scale in her suitcase. So she wanted the same one, to make sure that she wasn't getting any variability.
What I like about Don, and really he represents, I think, bariatric surgeons in general, they take it seriously from a psychological perspective. There's a lot. This is a multifactorial, multidisciplinary situation. So whenever you do, look for medical help for weight loss, you have to look at everything like we've looked at today, from the Alan Mendel's perspective of the different types of nutritional improvements and exercise capacities to the different medicines, and then a caring bariatric surgeon that has a lot of experience and will put it all in context. So with that, I wanted to really thank Dr. Waldrop from coming all the way from the West Coast, from Beverly Hills, to give us his perspective. It was very illuminating and very, I think, sort of the ice, the cap on the entire discussion that says, okay, now you've tried all these things. Here's a solution that I can give you. So it should give a lot of people hope that this is a fixable problem, and some of it, if not all of it, is not your fault. And so we want to give people hope and make it simple, and I think we've simplified it a bit. And I think with that, we're going to go to Dr. Montague is going to come in and talk to us a bit about, once you've lost the weight, once all this has worked, how do you contour your body to a point that you're actually in a shape that you wanted to be in. And so he's going to talk about the plastic surgical perspective, and then we're going to end with that. And really great appreciation. Thank you so much for coming, Don.
Great show. Thank you so much.
So to round out what I think is, the perfect episode, we have, after you've lost this weight, you've lost significant weight, you've gone from either very overweight or obese to back to where you would like to be or close to it. A lot of people want to use some of the plastic surgical techniques to sort of do some body contouring. So I asked probably, I think, one of the, if not the best plastic surgeon in our area, if not in the country, Dr. Andrew Montague, was kind enough to stop by, break his busy schedule where he works in Miami. Dr. Montague trained at Hopkins, and then with me at the University of Miami. We go back a long ways. He has treated a lot of my family members, most of whom I can't say that he's treated, as well as much of our community. And he's going to tell us about one of his kind of favorite things to talk about, which is body contouring after weight loss. So let me hand it over to you and give us your synopsis.
Well, thank you so much, and first I want to say thank you for inviting me with these other esteemed guests. And you just made mention that this is, it's a multifactorial situation and a multimodality approach. We all see the same patients. You may be seeing them for preoperative clearance, or Dr. Waldrop may have done a gastric bypass. It's all related. So, and these are difficult. There are a lot of difficult choices here people have to make with surgery, no surgery.
What's your typical case? If someone comes in after bariatric surgery and lost weight, maybe they're still on some medications for it afterwards, or not. What's your your lady that just lost 150 pounds? What do they usually
Right.
ask for?
And I do want to just make a quick mention, that food keeps coming up. What do I
Right.
eat? Patients ask me to. A very simple little mnemonic or thing to remember is that if your grandmother recognized it as food, it's probably good to eat.
Right.
If it comes in a package, probably not so good. We a lot of times we know, but it can be difficult. Maybe it's a nurse who works a night shift. Dr. Mendel talked about, the catecholamine, cortisol, and things like that. But we know what to eat. We eat too much. We don't always eat the right things. But, ultimately a patient makes it to my office. Maybe they've had a bypass. They've lost it on their own. If they come in too heavy, BMI over 35 is risky, 40, I'm going to send them to Dr. Waldrop first. Let them do, if they can't do it on their own, the bypass can be life-saving. And again, my surgeries are not weight loss surgeries. They're contouring surgeries.
So tell us about them.
So somebody comes in now, they've lost 50, 100 pounds. And we think about the before surgery, surgery, after surgery. Before surgery, it's very important that a person has stabilized their body weight, because they could lose 50, 100 pounds in 6 months, as Don said. They're not at their healthiest at that point. They're in a catabolic state. They're breaking down. They've been breaking down for months. And it's the opposite of anabolic, like anabolic steroid, Arnold Schwarzenegger. So we want that body weight to be stabilized for 6 to 12 months. They've lost the majority of their weight. Give it 6 to 12 months. You're going to be much healthier. You're going to heal better from your surgery. Okay, very important factor. You're going to go see your doctor, make sure your other comorbidities, your high blood pressure thing, everything is under control. Okay, now these are some of the longest consultations that I have, because if somebody's lost a lot of weight or deflated, as we sometimes say, it affects the whole body. And I also like to mention, these are not things that these people can fix. Just like stretch marks after a baby, this skin that is permanently damaged with stretch marks, you cannot fix it. Lose another 100 pounds, you're still going to have that stretched skin. You can't fix it. So that helps. So people know they've done, they've saved their lives already. They lost 50, 100 pounds. You can't fix this. So now we get to talk about some of the good stuff. How do we make you look good again? You cannot address an entire body in one surgery. It's not safe. And safety, of course, always paramount. So as Don was saying, it lets the patients have some input, some say in what they're picking. I do too. Certain things lend themselves to surgeries at the same time, such as the arms, the breast, and the chest. But somebody may say, listen, it's my tummy and my breast, that's what I want. So we work with it, but we emphasize again, it's not going to be one surgery for most people. And all of these surgeries, sometimes we combine with liposuction, but most of the time the best candidates have fully deflated or lost all their weight. Though sometimes some liposuction can be used to supplement and improve our results. Again, not for weight loss. So we'll talk for quite a while about what's going to be the best combination of surgeries for this particular person. All of these surgeries involve incisions or scars, and sometimes longer scars because they're bigger body parts. But in general, the massive weight loss, as we refer to them, gastric bypass type patients, they're the most accepting of the scars. They have the most to benefit, by taking off sometimes tremendous amounts of skin. And that helps people with everything from hygiene and being able to exercise better to, of course, the way they feel about themselves. I mean, it can be transformational. So we may combine surgeries, as I mentioned. An upper body lift might be the arms, the breast, the chest, but sometimes we're starting with an anchoring procedure, which is sort of an extended tummy tuck or abdominoplasty called belt lipectomy. Especially if somebody has problem with the thighs, we want to first have those anchor points set. There's some analogy with the breasts as well, but that's the idea. So we're going to pick the surgery that person feels, these are the most pressing things for that person.
Right.
And make sure they've got their medical clearance, they've seen Dr. Sofer, everything is good.
So let me ask you, if a patient comes in, they go, listen, I want a little liposuction, I don't like my belly, what do you tell them?
It's generally not this patient. This patient is going to come in with 12 inches of skin hanging over their belt line. So again, sometimes a little bit of lipo is used, especially for arms, to help with contouring, and they can be done at the same time. But most of these surgeries are going to be big excisions of, large amounts of skin that are hanging. People come in, they flap their arms, they have skin hanging 12 inches. Same thing over the pannus, the belly, and it's very difficult for hygiene and things like that.
Can you so use the belly as an example, and I think that's probably pretty relatable, whether you are formerly obese or not. So things are happening, in your belly that's expanding. Someone loses all that weight. It's literally hanging over their waistline. It's just this extra fat that's there. Just say what you do. I paint a picture for us, and it doesn't have to be as gory as maybe I'm hoping it'll be, but paint a picture for what you literally have to do to restore that person to something that is aesthetically pleasing and then has all the downstream effects.
And probably most of the audience has watched the YouTube videos anyway on the surgery.
Right. I may be the only guy who's not seen it.
So a lot of times we'll illustrate how liposuction can remove more fat, but it's not going to address the main issue, which is the excess skin and the contour.
Right.
So again, I'll show somebody this is liposuction alone. The skin is going to hang. Your arm will be smaller.
Right.
But if you want the arm that you used to have or other people, then that's going to be requiring essentially an elliptical incision of that excess skin.
Okay.
Now, of course, that's going to create a scar. Today, our scars, we have, so many new techniques, better ways, putting tension on what's called superficial fascia instead of the skin. We've got scar creams to use afterwards. And again, you're dealing with a population that's more accepting of scars than anybody else. So they might come in and they have this big thing hanging over,
right.
And we're going to mark.
You're going to make a whole an ellipse, right?
Yes.
And then you're going to.
And we're going to hide that. We're going to hide that incision still in a bikini.
Right.
In a bikini line.
Right.
And we're going to take off all that skin, pull down, make it nice and tight.
Right.
Everything is great. And I do want to mention too that people have to take very seriously the recovery period. No shortcuts. 2 weeks minimum for most.
What about the possibility of regaining weight? What is that? You want to mention side effects or downsides to? Is it harder? Is it?
So again, I would say this is not so much gaining weight. I mean, it's behavior modification is key, even for a gastric bypass, as Dr. Waldrop will attest. So they're not usually going to gain weight.
So in your experience, they don't usually. Once you have this,
not at my point. No.
Yeah, at your point, they've lost the weight. It's been a year. They've got some flappy areas, and
right.
you can go in and excise them. And with the exception of a small reduced scar, they really can regain their form.
Yeah, and also yes, but I want to mention that again, this damaged skin, this issue of damaged skin that can't recover, it's crucial. If somebody, you or I, gain some weight, maybe you, gain some weight, and you lose it, that skin is going to contract. Same thing after surgery, we've eliminated most of that damaged skin. If they gain 5-10 pounds, as most of us do around holidays, they can lose it. They're not going to ruin their surgery.
Got it. So it does have a little bit of a shrink and swell capacity. You leave a little room in there, and that's natural.
The human body,
Right.
can accommodate. We've had people that have had children after breast surgery, tummy tucks, and they have not ruined their surgeries. Have to watch how much weight they gain or
Interesting.
other
So
factors
even
involved.
after
Absolutely.
pregnancy and
Absolutely.
everything comes with, it kind of bounces back after. That's interesting.
They have that potential, yes.
That's great. That's great. That means that you're having surgeries, I see, to regain your form.
Right.
The form meaning the general form. One would have to expect a certain amount of. You're going to have surgery. It's not all. There's going to have to be some incisions. But what we've seen post-bariatric surgery that Dr. Montague in particular and other surgeons from other parts of the country are doing is really remarkable at the form that comes back. And then with the creams, and I've even seen elements of skin tattooing and stuff the dermatologists do where it's like a new person.
Right.
And that level of hope needs to be in every obese patient right now, that they can get off medications, they can get off of their depressions, they can get off of their insecurities, and ultimately return to a form that was once to be theirs. And with all of the experts that we've had, with you being the sort of the really the cherry on top, it is remarkable what we've been able to do as humans. Yes, maybe we got ourselves here by industrializing our society and supersizing our food and genetically modify whatever, but we're also able to fix it. Kind of like COVID, we kind of caused it, I think, and looks like we're going to solve it, it seems. So, yay humanity. So do you want to summarize any of the stuff that you do with the contour, post weight loss contouring? And
Well, again, I think, it's important to know it's surgery, and we take it very seriously, and patients have to be committed before, during, and after. But it's really not a plug, but if you look at my website or any, you'll see things, people see things and they say, I didn't know that was possible. I had no idea that my tummy could look like that, my arms could look like that. Again, my breasts may be better than they were before. But it is surgery. You have to be in, your health, your nutritional status has to be good to heal. And, don't give yourself time afterwards. We'll take care of the surgery part. Again, it could be 2 and sometimes even 3 surgeries in some cases. But we'll get it done. We won't rush it. We'll give you a safe surgery, a great experience, and can give you back your body that you once had, if not better.
That's great. I don't think you could say it any better. So I really appreciate you taking time out of your, I know, crazy, busy days.
My pleasure. Thank you.
Particularly during the pandemic. Turns out that plastic surgeons have been busier than anybody because of a variety of reasons. But I know Dr. Montague certainly has. So I appreciate him and all of our guests. With that, I think I'm going to close the segment. We've covered really everything that there is in weight loss and obesity, and the hope is underlying everything that you can reverse and return to where we would all like to be. And I hope we've taken a complicated topic and, as usual, made it a little more simple. So thank you, Adam.
Sure.
And thank you all for listening. And remember, subscribe below and tell your friends. So we'll see you next segment. And thank you all so much.
Let's keep it simple. Start today.